I'll begin by introducing myself for those of you that I haven't had the opportunity to meet. My name's Amanda Christensen and I work for the Australian Respiratory Council, and I'm really happy to be co-chairing this session, the webinar this afternoon, with my colleague, Dr. Chris Lowbridge. So on behalf of ACTnet and the Australian Respiratory Council, I'd like to extend a warm welcome to everybody joining our webinar to this day from across Australia and the many Pacific nations, and acknowledge the First Nations people in each of those land-specific nations and territories. Okay, so our webinar today brings together nurses, researchers, program staff from across Australia and the region to discuss and explore a central role of nursing research in advancing TB quality and TB care and quality. We will hear from colleagues who are working in a range of settings and organisations from across the region, and we're all united in the work that we do and a commitment to practice evidence-based nurse-led innovative care in all of the work that we do. So I'd like to also thank ACTnet for the opportunity to provide a forum for us to meet. We have the chair of ACTnet on, Dr. Andrew Burke. So thank you to ACTnet for supporting our webinar and supporting the formation of a nurses special interest group in research. So again, I'd like to welcome all of you here to the session this afternoon, and I'll hand over to Chris to just give a brief background on ACTnet. Thanks, Chris.
Great. Thanks very much, Amanda. So I'm Chris Lowbridge. I'm a senior research fellow at the Menzies School of Health Research in Darwin, although based in Kiribati country on the mid-north coast of New South Wales at the moment. So for those not familiar with ACTnet, so ACTNet's a collaborative network comprising clinicians, researchers who are passionately committed to propelling scientific, clinical and public health research on TB in Australia and New Zealand and the region. ACTnet has a range of activities and initiatives to bring TB professionals together, such as webinars like this one today, journal clubs, podcasts and newsletters. And so if you're interested in learning more about ACTnet or signing up to receive updates about events like this one, I'll post a link to the website in the webinar chat. So with that, I'll now introduce our first speaker for today's session. So that is Ellen Donnan. So Ellen is a registered nurse, epidemiologist and public health manager at Health Protection New South Wales. She has over 15 years experience in communicable disease management. She's worked in TB since 2013 and currently manages the New South Wales TB program. She's also represents New South Wales on the National TB Advisory Committee and is currently a PhD student at the University of Sydney. So over to you, Ellen.
Thanks very much, Chris. I hope I am sharing my screen. Excellent. Okay, thanks very much for joining today. I was invited to talk to you, and I'm going to attempt to give some of the background that sort of brought me to TB-specific research, with a very much disclaimer up front that, one, this is very much the work I've done is very much implementation research, not pure theoretical or medical or clinical research, and the other is that it's all very much a work in progress. So I'm not actually going to report on any results, just more going to talk about the work so far and the progress. Okay, so first of all, I'd just like to acknowledge the Aboriginal people as the traditional custodians of the land, waters in which we all work, live and learn. I am on Gamma country this morning of the Eora Nation. This artwork was commissioned recently by Health Protection New South Wales by Tracy Van Oplo and is designed to really represent the interactions that health and environment play in Aboriginal community lives. So first of all, my background. You can see here, this is me as a very young whippersnapper nurse in my first year, end of my grad year at St Vincent's Hospital in Melbourne. So my background initially was in microbiology and immunology, but in my Bachelor of Science, but I decided pretty quickly I did not want to work in a lab. Apologies, any lab people on. I ended up in a Bachelor of Nursing, upon which I decided I didn't really want to work on a ward from my experience. And I guess I did do obviously some acute care through my graduate year, and also then through casual banks, some hospital in the home, and some infection control on my pathway towards a Master of Public Health, which I undertook when I was also reasonably younger than I am now. So I actually went through a Master of Health more into the epidemiology side, but did maintain my nursing registration and skills throughout that. But my disclaimer is that, yeah, I kind of have a both role here now. I worked as a TB epidemiologist in Queensland for a few years, and now I work in the Communicable Diseases branch in New South Wales Health, or Health Protection New South Wales. And my role is expanding. So I do look with TB, but also other diseases like acute rheumatic fever and some of the bloodborne virus STIs and mpox. But most importantly, in terms of TB, so how I ended up doing any TB research? Well, it turns out I fell in with the right or wrong crowd, depending on how you put this. So Justin Denholm, some of you may know, Victorian TB Program Director, also prolific researcher, might have done some bit of push and shoving at some points. Professor Vitaly Sinchenko, who runs the New South Wales Microbacterial Reference Laboratory, and we've done a whole lot of work in integrating whole genome sequencing into public health for TB. And Professor Ben Murray from University of Sydney also is played a nudging part in me towards this pathway. And it wasn't supposed to be, but these three people managed to convince me that I should write a paper on use of whole genome sequencing for TB public health activities in Australia. I'm not sure why, but anyway, it was written into and published in 2023. And in collaboration with Justin particularly, but all of these people, there were a number of other outputs about whole genome sequencing of public health standards that came, including one where, I know why. Justin wrote an article on best practice standards for whole genome sequencing, and I'd worked with him on that, and in terms of the design and things. So I ended up as senior author on this paper with, people that had 10 times more research experience than me, above me. And this kind of dragged me in, because I kept going, if I'm keeping doing this, and it's just, maybe I should actually be thinking about some of this counting towards something. So I, I would say 3 or 4 years of deliberations, I finally bit the bullet and enrolled in a PhD. And the topic of that at the moment is challenges and opportunities for enhanced TB control in New South Wales, Australia. But like everything, it's a moving feast, and whether or not that's what it ends up being named at the end is this is already the 3rd title, so we'll see. The work done to date really has been a number of things, and it's quite a diverse project, and pulling it all together is going to be a challenge at the end. But firstly, I looked towards TB elimination, the action framework for low incidence countries that WHO published in 2014, and tried to really look at our setting here in Australia and New South Wales, and how it went towards the eight areas that WHO considered important for low incidence countries. That led to a publication on progresses and challenges to TB elimination in New South Wales, which was published earlier this year, which was an interesting lesson in how research and work dynamics can play, and particularly in regards to approval processes, particularly when you are acknowledging some areas where we could do better, I think. So this was a big challenge for me. It ended up needing to be signed off by the Chief Health Officer of New South Wales, Dr. Kerrie, and it actually has in some ways made my life a bit more difficult in terms of research, because the follow-up paper to this was really the good things that we've done, and some of the other opportunities towards TB elimination, unfortunately, still hasn't got through the approval processes. So work in progress, and did teach me some interesting lessons about making sure you are doing, while being very truthful, you're also aligning with your, making sure that the workplace goals. It's not clashing. It's a real interesting juxtaposition between research and when you've got a position in the area. Another piece of research we're also doing, which does have a bit of a quality improvement bent, but does have some research in terms of looking at outcomes as well, is we're looking at a clinical audit of all TB contact screening in New South Wales in 2023. Now, this is really the first project, and this aligned with some of the New South Wales health goals, particularly health protection on trying to improve contact tracing completeness and outcomes for contacts identified in New South Wales. So this was quite accepted by my workplace as a research project because it aligned well with the goals that were set. Having said that, I don't think, again, would I choose to do a statewide project which involved governance applications to 21 facilities, of which has taken approximately probably 16 months. It has also involved our data collectors being required to become contingent workers of 16 local health districts, and including the very, very last one, we got a hospital, one of our metro hospitals, we've been trying to get contingent worker status for 6 months since the governance application was approved, and that finally got through this week. So it's kind of just interesting lesson for me in terms of the ethics and governance requirements. And I think one of the things that would lead to something I've certainly been told is sometimes smaller projects done well are a good start, maybe rather than fighting with, negotiating with many, many governance committees. But we're going to get there. I may change my mind in a year's time, be like, best thing I ever did. Some other things done, including looking at particularly the integration of genomics and what that looks at in terms of identifying clusters and opportunities for public health control of TB or public health management. So this was a paper that was written by Dr. Archana Coriola, who works in the PM Blue Mountains, and looked at a TB cluster we've had in Pacifica populations. The reason I mention this is there's lots of clusters we have, and some of them bigger than others. This was quite a large one, and trying to understand how transmission works in our settings is of real interest to me, and also in this case links well with some other work in terms of looking at our cultural engagement and how various communities experience TB in Australia. So one of the other projects that we're currently in the midst of working towards finalising data collection is looking at the experiences of Nepalese people and understanding how they interact with the health system in Australia. This is a qualitative research project between Health Protection New South Wales and the University of Wollongong, with much support from Associate Professor Chris Degling at the University of Wollongong. We've interviewed 15 Nepalese TB patients, and we're currently trying to organise to interview community leaders. I think we've got hoping to have 3 done by the end of this week, and a few more in the next couple of weeks. Again, an interesting project. Recruitment of patients took a while, but not too challenging. But community leaders, everyone is very busy, and so asking people to weigh in on the topic of tuberculosis, which they may not, be very aware of in Australia, or amongst all their competing priorities, is obviously challenging. But we're hoping to have the data collection completed by the end of the year and have some results to report next year. It's been very interesting for me to hear some more of the patient stories, and not just of their TB stories, but how they interact with the health system in general as well. We're hoping that will lead us to be able to do some more health promotion work with primary care and Nepalese communities as well. So there's some other opportunities that also have sort of come up, or things that might be looked into but not sure yet. So there's the sort of outbreak or cluster investigations often ongoing. I think there's some more work that could be done in contact tracing, really looking at some of the qualitative information about people's understanding and experiences and how we can better engage with particular communities. We know some communities engage better with contact tracing, and others, really struggling to do anything much, even within the household, let alone outside the household. I think there's a real opportunity. There's obviously been some work done in Victoria and a little bit in WA on TB infection management in primary care, and I think there's still challenges to that, particularly with the registration status of drugs and including vaccin and rifapentine, and also PBS as well, and working with primary care at high-risk areas. So I think there's some further work that could be done there. More cultural engagement research is something we haven't done particularly well on a statewide level, at least. Here, been doing some work on, in New South Wales, we're about to get a single digital patient record, which will mean a single electronic medical system across the whole state in about 3 years' time. So how can that be leveraged? How can we make sure that data is being collected in a systematic manner in a way that we can actually use it in the future for both sort of monitoring from a local level and clinic level and also at a statewide level? And also models of care is something particularly, I think, be very interesting to see with the new launch of the nurse prescriber models. Obviously, there's the nurse practitioner models, but this new nurse prescriber model that's been announced by AHPRA, I think, has a lot of potential in terms of management of TB infection. And I think some work in that space, sort of in a health system or health service type research way, would be really interesting in the future. So I guess these are some opportunities. I've sort of touched on some of the things that I've been looking into as well. And I think I just wanted to briefly mention, I guess, some of my thoughts on this. I guess I've very much been like a PhD is very, it needs to be quite original, theoretical and all this, but really I'm advised, and I hope that really, implementation research and looking at that has a lot of value. I think, looking at things and linking it in with your organisational priorities, like if there's areas that are of concern to management or things, if you can link in research with those type of areas, they tend to get a bit more support in undertaking that work. I guess everything takes longer than one expects, particularly as, a lot of us are working as well as undertaking research. So certainly, I always expect time zones will take longer, and then they always take longer than that. And I think it's about also being realistically with scope. So, I think it's Peter Massey, who probably will be on here later. He says, start small, start well, with really well conducted or well designed things, and you can get some good answers. You don't necessarily have to do silly things like try and do stuff statewide in New South Wales, where we've got a very decentralised system. But they obviously have value too. So, so this was just a little introduction, I guess, to some more operational research, some of the things we're undertaking at the moment in the New South Wales TB program, and also some of the opportunities I see in terms of what could also be done in the future. And thanks very much to my team, all the clinics that are also supporting some of this research, and my 4 supervisors who are very proactive and try and keep me on track.
Thanks so much, Ellen. I think that was a really fantastic talk to kick off today's session. You highlighted some really important, challenges that people doing research can face when it comes to it, particularly around managing those sort of conflicting priorities between your organisation and other stakeholders. And it was really great to see some of the research opportunities that you highlighted too, and hopefully that gives people online some ideas for things that they can be thinking about looking at in their own settings. I'm conscious that you do need to sort of duck off, but hopefully you might be able to rejoin the question and answer session at the end. So I might just check if there's any pressing questions for Ellen before she has to leave us. feel free to raise your hand or post a question for Ellen in the chat.
While people are thinking, I'd just like to say, Ellen, I thought that was a great introduction about how you fell into research, I guess, how sometimes that evolves in a role, but those opportunities you presented may resonate with other people online, other programs, other jurisdictions, other countries. So one of the features of today is really about sharing information and looking for opportunities to network and collaborate. So thank you for sharing the great work that you and the program are doing and the opportunities you're looking at investigating or getting into. Andrew, did you have a question?
Oh, hi. Thanks, Ellen. Andrew Burke in Brisbane. Look, I always like asking leaders like yourself, what would you do differently if you're starting out? Are there any lessons you've learned that you'd pass on? Maybe you need to sleep on that one, but
there's a big smile there. Look at that.
Look, I think I have done some research with people before, very much just mainly data-based in the past, with the existing collected data sets and things. I think that I kind of think I probably could have planned a little bit better in hindsight. Certain things I ended up doing that now, were still valuable to do, but aren't necessarily going to contribute to my PhD. I think that I was pretty ambitious with trying to run a statewide project in New South Wales. I think we could have scaled that back. I mean, I think it will be very useful and very interesting, but the organisation and I think it's been a big lesson in dealing with making sure you ask ethics committees and governance committees what they want before you put anything in the system, because it just varies so differently between ethics committees and between governance committees, and two local health districts, and you're getting asked to sign data management agreements, and another one's like no worries at all, just go, and another one's wanting contingent worker status and wanting you to do 50 courses on hand hygiene before you enter to collect data that takes 3 hours to collect. Anyway, so that wasn't very well thought out, but I think good planning is not wasted, and we probably could have thought a little bit more about some of those things.
Thanks, Ellen.
Perfect. We'd encourage you to either pop your hand up if you have a question, or to write in the chat box, and we will take questions as we go through. I can't see, Chris, there's any questions there? No? Nashita has very kindly given us the mailing list link for people to sign up with ACTnet, and as we said earlier, we'd encourage you to do that. That is there already, but as we go through, if you'd like to put a question in there, we'll take those, we'll address those as we're going through and as part of the discussion at the end. So thank you, Ellen, very much for that presentation. It is now my great pleasure to invite Mareta Hauma to present to us. Mareta is my long-term colleague and friend. Mareta began her nursing career in 1986 and has extensive experience in TB active case finding across the Pacific. Mareta has worked in eBay on an active case finding TB project with the Marshall Islands Ministry of Health and US Centers for Disease Control. Mareta now leads the Pearl Plus project in Kiribati, and her role is as the lead study nurse. The Pearl Plus project is a multi-disease intervention study focused on TB, leprosy, hepatitis B, and scabies. Mareta is going to speak to us today about TB and leprosy screening and prevention, nursing insights from the Pearl study, Kiribati. Thank you, Mareta.
Hi, everyone. I'm Mareta, and I'm going to present nursing insights from the Pearl study in Kiribati. I have many slides to show you, but I have only 15 minutes, so the presentation will be made available to you. The Pearl study is an implementation study. Next slide, please. The POST study is an implementation study. We're studying a TB leprosy active case finding in Kiribati. In Kiribati, the capital of South Tarawa, where 60,000 people live, and this is half the population of the whole of Kiribati. Recently, we added hepatitis B and scabies to our protocol. Next slide, please. Kiribati is situated on the equator, halfway between Australia and Hawaii, as shown on the map. Next slide, please. This is a snapshot of our country and our health. It is a developing country with low employment and with many challenges. Next slide, please. We have acute and community services and disease program, and we report to the Secretary
of the Minister for Health.
And we report to the Secretary and the Minister of Health and Medical Services. Next slide, please. As shown here, this is a WHO 2023 data. Kiribati is the number 6 higher rate of TB
in the world.
In the world. Next slide, please. Kiribati is the highest leprosy in the world, reporting approximately 100 cases each year. And next slide, please. This is our project design. You can see a test and treat design. Next slide, please. We identify households for screening by using geospatial technology, which will link to the census data of 2020. Next slide, please. This is the description of our methodology. We announce, enumerate, screen over 2 days, refer presumptive cases to the National TB Program, and treat preventatively TB and leprosy. Next slide, please. These are our resources we use. We educate, screen, treat, and treat our study participants. Next slide, please. We had to recruit and train our team to implement the study. We have employed 35 staffs in the health study. And as shown in the slide, mixture of doctor, lead nurse, registered nurses, as well as community health workers and lab staff and project officers. Next slide, please. In the households, we capture our data live on iPads and sync with the REDCap database each day. Next slide, please. Of course, to increase participation in the study, we have to engage the community. We mainly do this through household enumeration, community forums, and Facebook posts.
Next slide.
And next slide, please. In 2022, we did our pilot study on the village of Nanigai. As you can see there, it's encircled. The population of Nanigai is around 1,256, and we screen approximately 1,000. We use the meeting house model, rather than household visit during the pilots. Next slide, please. We then moved to the most densely populated village after the pilot, Beso on Baidiki screen. And we completed Beso in August 2025 this year. And we've just finished Baidiki, next village to Beso, which is the government village. You can see from the data, we have screened over 17,000 people. And also on the table, in here, we registered population of 17,352, and we treat 15,668 with the MDA coverage of 90.3% only on South Tarawa. And this is the treatment or prevention to both. Okay, next slide. And these are our challenges. Since Kiribati is a developing country, we have many challenges. These include logistics, staff turnover, absenteeism, community participation, transportation of staff, specimens, and patients, and working with, but outside of the existing health service. Okay, next slide. With the achievements adapting, we moved from meeting house screening to home visits in response to community to maintain our coverage. We kept screening despite all the challenges, stock out and no staff. We have 35 skilled staff for Kiribati. We meet regularly to review our data, report, and plan, and we have built strong relationship with government, health service, and community. Next slide. In these lessons learned, there's more TB and leprosy than we thought, double, and multi-disease screening is possible, but slows progress. Infrastructure and logistics underpin successful disease screening, treatment, and prevention strategies. Working outside the system requires increased time and resources. Relationships are key. Patience is a virtue, so are consistency and persistence. And last slide. This is just greetings. This is the full team of this is the Pearl team, and greetings from the Pearl team from Kiribati. Last slide, which is just the encouragements to the people, and as shown on the slides. I think that's all I can say or I can present for this.
I have 4 minutes.
And I have 4 more minutes. If you have questions to ask, you can ask questions. Myself and Kerrie are here if Kerrie can help out too with answers. Thank you so much.
Thank you, Mareta. So let's have a look. Are there any questions for Mareta from the group?
The camera. Oh, my.
Went very well.
No? Let's have a look. There's a question from CNMI Mareta. How were the 35 staff funded? That's a good question.
There, from there.
No, hang on. All right, you're right. Go for it. Answer. How were they funded?
Thank you for the question. Maybe I give to the project coordinator who is sitting right beside me. Okay, Kerrie, please can you respond to the question? Thank you.
Yeah, sure. Look, what we didn't put, but you may have seen on that last slide, was that our chief investigator team, led by Ben Murray and Warwick Britton, submitted initially for an MRFF grant, a very large, one of the biggest grants that Sydney Uni had been successful in. And they recently followed that up in 2024, having demonstrated their significant achievements to date and with recognition of the size of the problem for Kiribati that TB and leprosy were, DFAT provided funding through their PHR grant mechanism.
So Kerrie, just acronyms for people not on. So the Medical Researchers Futures Fund was the first group that funded this research proposal, and then given the success of the research proposal and the benefit that was being shown, the Department of Foreign Affairs and Trade, through the Pacific Healthy Partnership Grant, is that what it is? Scheme, extended that funding so that the team could expand, scale up, and have a multi-disease focus. Yeah?
Yep. So both government grants.
And I guess the question from CNMI is that within the existing funding and staffing levels, a project of such screening 60,000 people over a 4 to 5 year period would be extremely difficult. So the team works with, alongside and in collaboration, but the funding and the team are additional to the National TB Program staff. And being led very well by Mareta as the in-country lead nurse, taking the skills that she learnt from the Northern Pacific to the south, back to her home country of Kiribati, and helping the people of Kiribati.
Thank you.
There are many people online from the Northern Pacific who know Mareta very well.
Yeah, and we think our colleague Berica from from our national TB program did join earlier. I think she may still be online. Who we made a lot of work for through this screening.
Perfect. Let's see if there are any other questions here. There's another question here. Let's have a look. Conducting which part of the Pearl study was the most challenging among all that you listed?
Sorry?
What's the most difficult part of everything you do? Running out of drugs?
No, that's not.
What do you think?
Those are the attitude of people, Yeah.
Okay.
Well, with that question, I think that's a very good question too. And encountering a lot of challenges, as I mentioned, but most of all, it's about the people attitudes, that is our most challenging problem, since we've been just moving from Beso, going further down for more villages. So if the community really supporting all this, screening, then there'll be no problem. We can finish as fast as we can as the team moves. But the problem now is the attitude of people this is the challenge that we face every screening. But we'll try. We already raised this up to the Ministry of Health as well as the House of Parliament, and we hope to receive good response from them. But that we haven't received them yet. We're looking forward for a good response from them. We hope that from the very top people they can help us. The team, to go ahead without any problem by the community.
Yeah. And on the positive side of that, the coverage is considered very good.
Yes.
Screening coverage?
Yeah, screening coverage. But there's a lot of work, follow-up work that is done to support that participation. So, yeah.
I think you both raise an interesting point. I mean, we think about community engagement and engagement in the screening activity, but it's not static and it's not one-off. It's something, Mareta, your team is working consistently to ensure as you move to new villages or to get those really high screening rates. Community engagement is an ongoing and really important part of what you do, isn't it?
Yes, we've been doing that, and we never miss all these community engagement, but it's just the attitude of people that we cannot force them to, to be part of the screening. But we try our very best with the team.
Counseling.
Yeah, counseling. From now, good counseling, it will. But we don't have a problem since we have a very good coverage of the screening, and we try to. Start. Yeah, we even have a late start to catch up with those that were left behind, or those that they go to work and they have to come back after work, and this team has to catch them up. So that's not a big problem. But we try to get 100% of all these people.
80% will be good. Yeah. 80%. Our target was 80%. So they're definitely meeting the project target. I'll just, the only thing I would add to that is that in that late start team, the team are screening from 9 o'clock in the morning till 7 or 8 o'clock at night.
So do you think, Mareta, that having household enumeration and screening as well as that community model of screening, those two different models have impacted on your high screening rates?
Like the first model that we used before, it was like Maneba, where we go and screen everyone in the Maneba. People, they come to the Maneba and we do the screening. It was okay, like in Peso, but as we go halfway to, towards the end of Peso, it's kind of, getting less participants. And that's when we changed the model from screening Maneba to home visits.
Mm-hmm. Yeah. And there's a couple of other questions. Did the grant cover treatment as well for TB infection, active TB and leprosy? Maybe that's a Kerrie question.
Yeah, Kerrie.
Sure. So as Mareta stated, or maybe we didn't state, but as in the slides, we refer people with active disease to the National TB program and to the Leprosy program. The study funded, and we don't fund their treatment as such, but we do share our drugs and our medical consumables like expert cartridges, etc., with the National TB program, the treatment the preventive treatment was part of the funding, and so we do fund the preventive treatment
for TB and leprosy,
or both.
Yeah. Okay, perfect. And the final question here is, what would be the study's greatest strength?
Sorry, greatest strength of the...
Yeah. Well, there's many perspectives. Oh, yes. Yeah. Go
on. Well, we just discussed this, but Kerrie, since Kerrie comes and goes, and she knows, but in my experience, it's the team. The strength of the Pearl Project is the team, because if we don't have enough team, we know for sure that we will have less screening team to go. And I think that's the greatest.
A good team.
Strength, yeah.
They are skilled. We're impressed by their skills, and they've done a lot of training to build on their nursing skills. And but I think the leadership, Mareta's previous experience in the Northern Pacific has been incredibly beneficial, and she's a good manager.
Well, thank you, Kerrie. What we experience through the screening, we do the TBT treatment. And sometimes along the course of treatment, some will report that they want to quit. But by the good counseling of the nurses and the health workers, we can manage to continue their treatment.
If you look at if the question is about the strength of the study, I guess the feedback we've had from other teams like ACT5 in Vietnam and from Dr. Dick Brostrom, who leads CDC in the Northern Pacific, is that the Kiribati team are achieving outstanding coverage and an engagement of participants through to completion of their preventive therapy. So they are very impressed at the research figures, study figures and the data that's coming out of the project. And I guess on the downside, we're slow. Yeah. Yeah. But that's a multi-disease screening model.
Great. Well, thank you very much, Mareta and Kerrie, for that fantastic presentation. We'll move on to our next presenter now, and it's a pleasure to introduce Dr. Jabel Foster, who is a nurse and researcher with extensive experience in TB control, epidemiology and health system strengthening in Australia and the Pacific. She focuses on improving access to TB diagnostics and services in resource-limited settings, developing nurse-led TB models, training frontline health workers internationally, and contributing to global research on community-based and point-of-care diagnostics. So I'll hand over to Jabel, and I'll go ahead and share your slides. Is that right?
Thank you so much, Chris. Good afternoon, everyone, and thank you so much, Mareta, for your presentation, and to Kerrie as well. It's such an impressive project, and I love hearing about the Pearl study every time. Thank you for that. It's a hard act to follow, that one. So hopefully this presentation all works. Excuse me for a moment while I just set up on my end. All right, thanks so much, Chris. I'll just let you know when the next slide is needed. So thanks so much for the invitation to present today. I'm very lucky that I get to speak about two of my favourite things, which of course are research and TB. I'm speaking today from the lands of the Gimor-Yidinji people in far north Queensland. As Chris mentioned, I'm a registered nurse. I've got my PhD. Over the past 15 years or so, I've worked in various clinical and operational roles in the field of TB in far north Queensland, Nepal, and with the Tibetan diaspora in northern India. Right now, I'm a research fellow with the Kirby Institute at UNSW Sydney, but based in Cairns, and am involved in point-of-care diagnostics research in remote areas. So today I am talking about the importance of nursing research with a TB lens, but I'm specifically going to present operational research, which typically starts with an observation and ends with a practical initiative. So this presentation will cover the work of three nurses, one from Uganda, one from South Africa, and another from the United States, who noticed something that others didn't notice, who asked questions that no one else had asked, who consulted broadly, and then who used evidence to improve patient outcomes. Next slide, please, Chris. Every system failure has a sound. Sometimes it's the sigh of a patient who has waited too long. Sometimes it's the silence after discharge. Or sometimes it's the "I'll come back next week" that never happens. So nursing research begins in those moments, not in labs, but in listening and in observing. So one of the best things about nursing research in the field of TB is that we get to move in and out of that biomedical model. We move in all those spaces in between. We get to see the moments when care breaks down, and sometimes that's the best place to initiate research. Next slide, please. So every nurse in this room already does research. we just call it quality improvement. You run audits, you figure out the best ways to track missed doses, you fix discharge delays, or you might redesign workflows. The only difference between quality improvement and research is what happens next. So when you measure it systematically, when you consult patients to shape the solution, and when you share it, that's research. Quality improvement's just the seed. So quality improvement can help you change things internally in your workplace and in your TB programs. But formal research, that's what gives you this kind of evidence-based wiggle room to make the changes that might be a bit more complex or larger in general. So now I'm going to show you how some of our nursing peers overseas have achieved this in their TB programs. And I'm going to start in Uganda. Next slide, please, Chris. Okay, so in a TB clinic in Uganda, there were low MDR TB treatment completion rates where the term non-adherence, non-compliance was commonplace. There were so many reasons for non-adherence. There was persistent physical suffering, anxiety, hopelessness, fear of death, social isolation, stigma, discrimination, abandonment by families and community, inability to work, massive costs to get to the clinic to get treatment, and a feeling of being cursed or punished. So all the reasons were bearing down on this TB clinic. In Uganda, this clinic had a case fatality rate that exceeded 25%, particularly for those with multi-drug resistant TB and HIV co-infection. So the future of someone newly diagnosed with MDR TB was terrifying. 1 in 4 were dying. So Sister Nasua didn't want to accept that. She didn't accept that care just stopped or that it just slowed down because of non-adherence. She saw that her MDR TB patients were suffering their way out of treatment. Not only were her patients in pain and fearful, but they were hungry and stigmatised, exhausted and losing hope. She came to understand that her MDR TB patients were experiencing unrelieved suffering on every level. And she came to that conclusion after consulting with her patients, and she realised the patients didn't stop taking their medication because they didn't care, but because treatment felt unbearable. Next slide, please. Sister Nasua believed that if nurses could care for the whole person and not just the disease, then their outcomes would change. But she worked in a clinic with a biomedical focus. And so what could she do? Enter nurse-led TB research. In nursing research, you're encouraged to seek answers beyond the biomedical model. She contacted some academics from the UK to conduct a randomised control trial where she teamed up with a couple of palliative care nurses. She educated them about MDR TB, and she set up a nurse-led palliative care program for her patients. Now, this palliative care program covered both inpatients in hospital and those that had already been discharged. So you might be wondering, well, that sounds a bit odd given that we always strive to keep our patients alive to get to the point where they complete their treatment or are cured over death for our patients. But at the time this study took place, which was in 2019, the journey to cure was that brutal, toxic, lengthy, injectable-laden treatment regimen. And despite curative intent, remember the risk for these patients of death was 1 in 4. So palliative care was introduced not instead of cure, but to reduce suffering and support survival. So this intervention was really simple. All the patients that were allocated to the palliative care arm of the study were first interviewed to find out what their most pressing needs were, and then those needs were addressed. And so some of the palliative care options that the study talked about were nutritional support, pain management, counselling, emotional support, both for the person and their families. There were visits by spiritual leaders, prayer. There was medication for nausea, diarrhea, constipation, and any skin problems. And there was weak opioid treatment available as well. So Sister Nasua's palliative care intervention improved adherence to 89% and produced an effect size of 0.61. So what that means is that patients who received nurse-led palliative care improved their well-being by a moderate to large margin compared to those who received standard care, which essentially was to pick up medication from the clinic. So in practical terms, that's roughly the difference between a patient who is struggling with daily despair and pain and breathlessness to one who is noticeably more comfortable, hopeful, and able to continue treatment. So this study was published this year in The Lancet, and the authors have recommended nurse-led palliative models to be incorporated into the Ugandan Ministry of Health TB guidelines. So this is a wait and see if that happens. So we'll go on to our next TB researcher now. Next slide, please, Chris. Okay, so in South Africa now, nurse practitioner Anna stood in a crowded MDR TB ward where patients waited days for a doctor to commence treatment. Everyone blamed staff shortages. This was, after all, an area renowned for chronic doctor shortages. But Nurse Anna saw a deeper problem. Policy wouldn't let nurses do what they were trained to do. So you see, under legislation at the time of this study in South Africa, only medical officers were authorised to initiate second-line MDR TB treatment. And this could only happen in a hospital. All rural or district clinics had to transfer patients to doctors at the hospital for treatment initiation, and that, of course, led to huge treatment commencement delays. So at the time of this study, clinical nurse practitioners could request sputum specimens and chest x-rays, interpret results, diagnose, monitor and refer patients. They could initiate treatment for drug-susceptible TB, for HIV and for other communicable diseases, but they were strictly forbidden from initiating treatment for MDR-TB. So this wasn't about whether nurses could manage TB in general. This was about expanding their authority from drug-susceptible TB to MDR-TB. So what happened next? Next slide, please, Chris. Enter nurse-led TB research. Nurse Anna teamed up with a doctor, and together they teamed up with a nursing professor at Johns Hopkins University in the US. Together they led a prospective cohort study that included 197 patients with MDR-TB. The hypothesis was that clinical nurse practitioners who initiate and manage MDR-TB treatment under a task-sharing model will achieve outcomes equivalent to or better than those achieved by medical officers, demonstrating that nurse-led MDR-TB care is safe and effective. So ultimately, in this study, patients managed by clinical nurse practitioners had a 61% treatment success rate, compared with 53% under doctors, with fewer loss to follow-up and similar safety. Now, although the treatment success rate was not statistically significant, both were well above the national average of 45%, proving that the trend is heading in the right direction and that nurses could deliver safe and effective MDR-TB care. So the outcome for this study was twofold. This study led to South Africa formally recognising nurse-led MDR-TB treatment initiation that was documented in South Africa's national TB guidelines. And then this had a massive flow-on effect for patients, particularly those that were living in rural and remote areas, because they no longer needed to travel to hospital to start treatment. Next slide, please, Chris. On to our final nurse. This final story is based in LA, specifically on Skid Row. So public health nurse Addie had been caring for people on Skid Row for years. For those of you who may not know, Skid Row is in Los Angeles in the United States. It's 50 city blocks with about 4,000 homeless people with very high rates of TB, HIV and substance abuse. So Nurse Addie had been noticing a pattern. People were agreeing to start treatment for latent TB, but many never finished it. So the clinics blamed non-compliance, but Nurse Addie saw the real issues. People weren't attending the clinic to collect their medication because of distrust and chaos and impossible routines for those sleeping on the streets. Enter nurse-led TB research. In this case, specifically, it was a community-based mixed methods pilot study. Nurse Addie redesigned the system by partnering with community health workers who had first-hand experience of being homeless. These were trusted peers from Skid Row who met clients where they lived, supervised doses and built relationships. So the results of this study were absolutely remarkable. Treatment completion jumped from 65% to nearly 92%. And that proved that partnership and trust could close a public health gap that medication alone could never fix. So after this pilot, the Los Angeles County TB program began adding peer navigators and community health worker partners to mobile TB vans, directly citing Nurse Addie's model as the example to follow. Next slide, please, Chris. So we've got 3 nurses, 3 countries. What did these nurses have in common? They didn't have huge budgets or new technology, but what they did share is a method. They listened first, they observed, they consulted the people affected, and they used data to improve patient outcomes. And they all demonstrated 3 really important elements of nursing research, which are curiosity, consultation, and courage. So today I've presented just 3 examples, and there are so many more examples out there in the literature, but just 3 examples to show you why nursing research is so important. The initiatives I've spoken about today were all context specific. They were all led by nurses who knew what was happening on the ground, and the improvements they brought their patients was immense. So there's no reason why you can't do the same. And next we will listen to Chris, who's going to explain how we can conduct nursing research. Next slide, please, Chris. So these are the 3 slides. Sorry, the 3 studies that the slides were based on. I'm happy to share these if anyone wants them. Otherwise, next slide, please, Chris. And thank you so much for having me today.
Thanks very much, Chibelle. That's fantastic, and 3 really powerful examples of nurse-led research. Thank you for sharing that.
Thanks, Chris.
Now, I think maybe we're a little bit behind schedule, so perhaps we'll just hold questions to the Q&A section at the end and move on to the next presentation.
Okay, so that's me introducing you, Chris. So our final presentation for the day is from Chris Lowbridge. Chris is a nurse and senior research fellow at the Menzies School of Health Research, leading TB research to improve screening, prevention and care in remotely low resource and First Nation communities. Chris has also worked with the Northern Territory and the New South Wales TB programs and the World Health Organisation. So I think Chibelle's presentation is a lovely segue into what Chris is now going to talk about, which is starting a research project. Thank you, Chris.
Great. Thanks very much, Amanda. And as the title of this talk suggests, it's really the aim of this presentation is to talk about just those first initial steps aimed at people that perhaps haven't had the opportunity to undertake or participate in research previously. I won't have time to get into the details of specific sort of study designs and implementing research plans, but hopefully this session will just demystify sort of, those initial steps that you might want to take to get started on a research project. And I guess just first up, I wanted to say that there's a lot of misconceptions around, what research is, who is a researcher and who can do research. And I think that these misconceptions can be barriers to people embarking on their own research journey. So I think it's important to recognise that research is not just done by people who identify as researchers. In fact, I'd argue that many of the best researchers are clinicians, because you're sort of at the coalface closest to the issues that affect patient care. Research is also not just done in laboratories. It's not just done by people wearing lab coats. Research is done in health facilities, in clinics, in hospitals, and in communities. Most research is not complex, elaborate clinical trials. Many good research projects are very modest in nature. You don't need big grants and lots of money to do research. You don't need to be a statistician or maths guru. You don't need to solve groundbreaking Nobel Prize-worthy research problems. A lot of good, important research drives incremental changes that improve the quality of care that our patients receive. But in healthcare, research should be everybody's business because it's what drives evidence-based care and best practice. And like Jabel already mentioned, many of the elements and skills that underpin research are things that nurses are already doing in their day-to-day practice. So we'll get into what these initial sort of steps are to embark on a research project. And the first and probably most important step is identifying the research problem. So in identifying a problem, you want to think about what matters to your patients and your service. Ask questions like what's not working or what could be done better, who's affected, and what evidence is missing. At this stage, it's also important to look at issues that are feasible and researchable. And finally, I would say it's also important to go with a research that is of interest to you and something that you feel passionate about pursuing, because it can be a lot of work. It can have its challenges. And so, working on research in an area that you're interested in and passionate about can make it much easier. The image on the right of the screen is a bit of a joke example from a BMJ Christmas issue, but what it does show is probably what many people who have ever worked in a hospital or health facility would relate to, an important problem, and a problem that is very clearly defined. And so this is the other part of identifying a research problem, is then clearly identifying what that problem is. And you can see in the abstract there that the problem is identified in the title, and we see very clear objectives, subjects, setting, and outcome. And so really defining clearly what the research problem is at this early stage will set you up well for all of the steps that follow. So moving on then to the next step, and we get to sort of reviewing the literature. So reviewing the literature achieves a couple of things. First of all, it helps to prevent duplication and prevent us from doing things that have already been done. And it'll help us to refine our research question. So I would suggest that you start with a casual search, usually just through Google. Have a bit of a search, read what others have done in the area, and use this information to refine your research problem, identify keywords, get initial ideas about how others have tackled the same or similar problems, and better understand the methods that they've used in doing so. The next step then will be to do a more systematic literature review. And at this stage, you'll probably want to review several databases, things like Medline, Google Scholar, PubMed, and so forth, using a structured search query based around your research problem, including the setting, population, and the issue. And so this will allow you to define more clearly what the gaps in knowledge are that you can address through your research. And I just suggest that at this stage, if you have access to a librarian, they're generally extremely helpful at helping you to do your literature search. Next, we'll move on to defining your aim, objectives, and research questions. So this is the step of the process that's about clarifying very specifically what you want to find out. The research aim, objectives, research questions, and hypotheses are all related, but each serves its own distinct purpose. Generally, with a research project, you'll have one overarching aim, and then a number of more specific objectives. But I would suggest keeping these limited, usually no more than 3 to 5 objectives, and your research questions generally align to your objectives. So if we look at these in a bit more detail, starting with the aim. So this is your broad, conceptual and overarching statement about what you want to achieve with your research. I've just put together an example from an area of TB research that I'm involved in around screening programs and active case finding. So this is just a made-up example, but to show, in this case, our aim might be to evaluate the impact of a new community-based TB screening program on case detection in rural communities. So this is telling us broadly what we want the research to do. It's evaluating the impact, but it doesn't really specifically tell you what we're doing. That's where the objectives come in. And so the objectives are derived from the aim, but they break the aim into specific actionable components. And the objectives are then used to guide us when we come to developing our methods and in particular our data analysis. Also to say that when developing objectives, it's really helpful to use the SMART criteria. So that's specific, measurable, achievable, relevant, and time-bound. And you can read more about that if you're not familiar. And to show an example of this related to the aim, we might have some objectives like to measure the number and proportion of TB cases detected before and after program implementation, to assess community participation rates in the screening program, and to identify barriers and facilitators to participation from community and health worker perspectives. So you can see that those 3 objectives relate to the aim, but they're more specific and, importantly, they're measurable. Next, moving on to the research questions. So these translate the objectives into specific queries that are answerable, and they're used to guide the data collection and analysis. And in this example, you can see our questions might be something like, how did the introduction of the screening program change the number of TB cases detected in rural communities? What proportion of eligible residents participated in screening? And what factors influence participation among different groups? So you can see that those 3 align against the 3 objectives. Just finally, to quickly mention hypotheses. So these are a testable statement predicting a relationship or difference between variables. And these mainly apply in the instance of quantitative studies where you're specifically testing associations between variables. So not in every situation you will choose to have a hypothesis. Moving on then to the next step, which is choosing your study design. And we won't talk in detail about different types of study design. There's different ways to group them and classify them, but just broadly, to say different kinds of study design. We have descriptive studies. So these are studies that ask, what is happening. Some examples there like cross-sectional survey, case series. Next is analytical studies. So these studies ask, why is this happening? And examples of this are case control studies or cohort studies. Next, experimental studies. So these are studies which ask, can we change it? And they're studies in which you're generally giving an intervention and seeing the effect that has in between an intervention and a control group. And so randomized controlled trials are an example of that type of experimental study. And then finally, we have qualitative research, and this is more asking around how and why do people experience something. So there's lots of different qualitative methodologies, but things like case studies, participatory action research, and so forth. But the important thing, I think, at this stage is just ensuring that your study design matches against your aims and objectives, and that it will allow you to measure what it is you need to measure to validly and rigorously answer your research question. So then next it comes to developing the methods. And so at this stage, you want to start defining your study population. So that is who will participate, as well as your sampling strategy. So that is how will people be selected to participate. And this is a step that requires care because we want to minimise the risk of bias in our study. And so developing a sampling strategy and defining our population will help to improve the strength of our study design. We want to, at this stage, plan how we'll collect and analyse the data. We want to be thinking about what kind of tools we need to collect the data and analyse it. And I've just given some examples of things that you might use for data collection and analysis. And we, at this stage, want to be documenting this in our study protocol primarily, and then potentially also a research data management plan. And what a study protocol, I won't talk it in detail about, but really this is really clearly and in detail documenting what your methods are, so what you're going to do and how you're going to do it. I would say at this stage, it's also really important to involve relevant experts, so people that have experience, particularly in the type of methods that you want to use at this stage of the process. Next, just to talk about getting approval for research. So all research must adhere to the principles of respect, justice, integrity, beneficence, and transparency. These are all outlined in the National Statement on Ethical Conduct in Human Research there, and you can look that document up and have a read. It is a helpful document. And most health research does require approval from a Human Research Ethics Committee. There are some exceptions, so things like clinical audits, public health surveillance, or research that only uses de-identified publicly available data might be exempt from ethical approval. But if in doubt, talk to your ethics committee before getting started. Getting approval from your relevant ethics committee is an opportunity for external review of your proposed research to ensure that it adheres to principles of good ethical research and that the participants' safety and welfare is protected by the researchers. Just some practical considerations when you're thinking about applying for ethical approval is that the requirements vary between different ethics committees, so make sure you check local requirements. Usually there'll be an ethics application form you'll need to complete. These tend to be similar between committees, but they do always slightly vary. So just make sure you're using the right form for the right committee, and that you're attaching all the documents that they ask for. A lot of research might require letters of support, such as letters from a data custodian, organisational leadership, work in communities, particularly if you're working in Aboriginal communities, for example, letters of community support can be really important. Also to note is that ethics committees have a set meeting schedule and strict deadlines about submitting ethics applications. So be sure when you're developing your timeline for your research that you keep in mind when those deadlines are. And also noting that usually you'll require some level of internal organisational sign-off from the management within your organisation, and that's something that can take some time to get signed off, so make sure you factor that in as well. Just to mention, we talked about study protocols and research data management plans in the previous slide. If you have a really good, clear study protocol, it will make the ethics application process much, much easier because there's a lot of crossover between the two. Next, and I think final step is just in terms of funding. So I guess first to note that many small projects can be done with minimal or no funding, but it is important to be mindful and realistic about what financial resources are needed. Some of the common costs that often get overlooked are things like, reimbursing participants for their travel expenses to attend additional clinic visits, printing or translating of consent forms and study resources. Journal publication fees can be pretty significant, so important to think about having funds to cover those sorts of expenses. Identifying funding sources early is really helpful because then you have the opportunity to work on aligning your proposal with funder priorities. It's important to prepare a good, clear budget of what your expenses will be and the timeline for your research. So many funders do have strict requirements around how money can be spent and timeframes for spending that money. So it's important to be able to adhere to those. It's really important to showcase the strengths and importance of your research proposal. So this is what we call research impact, which is typically the main sort of sections of a research grant proposal. And then the second important aspect is building a strong team with research experience and complementary skills. And this demonstrates a track record of success in research, which is something that many funders will look for when they're assessing funding grant applications. I've pasted some logos of various organisations that do or have funded TB research, both in Australia and overseas. And so just to wrap up with a little bit of last practical advice, if you're interested in getting started in research, I would suggest developing research skills ahead of time. So learning about data literacy and improving your data skills is really helpful. Doing good clinical practice training is really helpful. So that talks a lot about ethical research, and there's good clinical practice training that's available free online. If you search in Google, you should be able to find links to that. Attending journal clubs and things like today's session can be really helpful as well to improve your understanding of research and research methods. Identifying what skills and expertise are needed to do the research you want to do is really important, and building a research team that has complementary skills that will allow you to do the research is really important. Your research is really never done by an individual person. It really does require a team, and having a multidisciplinary team with a broad range of skills is really critical for that. Remember to keep it feasible. It's something that people can come unstuck with their research plans, is getting too ambitious. And finally, like I mentioned, just clear and detailed documentation throughout. So things like your study protocol and other documentation, really important to make sure that it's detailed, clear about what you want to do and how you're going to do it. And that's the end of my presentation. I put my email there or a QR code to get to my profile, and very happy for people to follow up with me with questions after the session.
Thanks, Chris. That was a great overview, and you broke down what can be really challenging for many of us, and broke it into great pieces for us to be able to navigate, I think. Now, there's a couple of questions. I know we're running out of time. Let's have a look. So this is from Dr. Uni. So there's thank you to Chris. Mareta was asking, how do we get a copy of the presentation? So Nishida, will we be sharing these on ACTnet, the recording with the presentations on the website?
Yes, if the speakers are willing to share that, we can definitely get that out as well.
Perfect. Okay, so earlier there was a link to ACTnet. If you go onto the ACTnet website, how long will it take to get the recording and presentations up online? It does take a bit of time, doesn't it?
Yes, about 2 to 3 weeks.
2 to 3 weeks. Okay. All right. So Jabella said, Chris, it's a good point about you don't have to be an expert in statistics or research design to get involved in nursing research. And then there's thank yous for Chris, and Dr. Uni has asked, thank you very much for the excellent presentation. My question for Dr. Foster and Dr. Lowbridge, one of the requirements at the University of Indonesia where she works is for research proposals to be funded. Is the presence of the international funding of an international partner? Please provide guidance on how we can begin building collaborations for research. And I guess that kind of takes us on to the discussion. I know we're running short of time about potentially what this group could do, or whether we could form a network or look to collaborate for the future. So I think, Dr. Uni, you raise an interesting point there. Chris or Jabelle, did you want to answer the question about...
Yeah, that's such a great question. And what Amanda is saying, it'd be wonderful if this group would come together and we could collaborate more in research. But in the interim, what you can also do is have a look at, I guess you need to select a country first that you want to work with, and you can go onto LinkedIn or you can go onto university profiles to find the people who are working in the area that you're interested in partnering up with research, and then just contacting those researchers directly. I think most universities have staff profiles available online. Do you want to add something, Chris?
No, I think that's a great suggestion. I think meetings like this, conferences and other sorts of forums like that are a really great opportunity to build those international collaborations. I know that there's TB experts in many countries that are always looking to start new collaborations, and people working in particularly in high TB burden settings that are also looking to get support from international experts and donors. So I think these kinds of meetings are a great way to bring people together.
Are there any other comments or questions from the group? Do people see merit, or is there interest in formalising this group, or, to under the ACTnet umbrella, to meet once or twice a year, or to have a network where you can contact? We've heard of great research activities and proposals today to follow up if you're interested, or, you know, there was interest from some of my Australian colleagues who are academics in mentoring others or working in collaboration with other people. So the potential for all of this is you know, as a nursing group, we could certainly form a regional network or look to support each other or collaborate. I think there is scope to do that if there's interest. Yes, from Kiribati, Mareta and the group are interested.
100% yes. That sounds wonderful.
All right. So yeah, go, Chris. Sorry, go.
I was just going to say, I think that's a great suggestion, Amanda. I hope that the presentations today have shown that, you know, you don't need to have really high-level research skills or statistics skills and things to do research. But I would say that if you are new to research, having the support of a mentor is really helpful. And so that's something that I think is a great way to move forward with this kind of work is setting up opportunities for mentorship.
Mm-hmm. So I guess if there looks like there's agreement from the comments and thumbs up and some hearts and some other comments. So I guess it's practically how do we start, and maybe we go back to ACTnet and back through the group and work out what the next starting point is, whether we send out information to everybody who's registered today, whether we do a survey about what people need, or whether we, you know, it's a bit like starting out with a research proposal. We need to be realistic and modest and take some small steps. But I think there's probably, you know, something we could do to get in contact with people to use this as a starting point, perhaps through ACTnet, maybe, Chris.
Yeah, I think so. Sounds good.
All right. If Andrew's still online, I can't see.
We did. I don't know if we've got time, but there were a few questions before the meeting submitted online. So thanks to everybody that did submit questions. Some of the key things that people were interested in were issues around nurse-led support of latent TB treatment, and the other area that was of interest was TB nurse practitioner pathway. And interesting that came up in Jabel's presentation, and also Ellen, you mentioned about advanced sort of practice and nurse prescribing and the potential for that in TB models of care, particularly around latent TB management. I wondered if anybody might have some quick comments they want to add around that. I think it's a really great area that nurses could lead research in.
I'm happy to briefly comment, Chris. Can you hear me all right?
Yeah, yep, go ahead.
Great. So I think, as I mentioned, I mean, I think there's a lot of scope within the nurse practitioner role, but it is quite a challenging pathway. And I think some of the things that have been challenging here in Australia is setting up that employment route for what that looks like and being employed in that nurse practitioner structure. Certainly not impossible. We've had a couple of people do it in New South Wales, particularly in regional areas. But the new changes to the Australian upper education up for registration, which is looking sort of at an endorsement of a nursing prescriber, which is someone who could be mentored by a medical practitioner, but independently prescribe a small limited scope of medications and things. I think is just so well suited for TB infection management. I mean, there's a couple of regimens and you choose the best one. You could prescribe side effect medication for nausea or that type of thing. And I just think there's a lot of scope there, but I think it's so new and there's still information coming. And I think it's having someone, I think it's something that we should do something in, but I haven't quite figured out how or who has the capacity to do so. It was raised as part of immunisation actually for us, but when it all seemed to make more sense for TB, and I think a real opportunity to address particularly really large number of migrant referrals that we receive with TB infections. So I think anyone's interested, doing further in that space. I think it's a really good opportunity in Australia right now.
Yeah. And I guess, Ellen, if we're thinking about nurse practitioner roles and specialisation, I mean, we have other disciplines in, family planning, sexual health, renal, breast cancer, other specialty areas have done it. But I also, with one eye on the Master of Nursing through the University of Western Sydney, I guess we would want to marry up some of those pieces as well and make sure that if there is that specialist university course, that it was meeting the needs. If we're going down developing a nurse practitioner pathway, we'd need, be sensible to look at how they might fit together as well.
Yeah, certainly there's been discussion about whether at a national level it'd be possible to do something about sort of making a consistent, I guess, model for TB nurse practitioner and how postgraduate course would fit into that. The nursing prescriber part I mentioned is a separate university course of 6 months. But, if that fit in some ways in terms of, the Master of TB nursing, that would, it's really an interesting space where Australia has been a little bit behind, I think, in some of other countries, particularly some of the well-developed countries and other high incidence TB countries. And I think it's, yes, certainly right for I guess finding out more about what nurses would want to do in this space as well and how it would overlap with their existing responsibilities.
Right. Well, I'm conscious we're already a bit over time, so probably we might need to wrap up now. But I think it sounds like there is some genuine interest in working together to support nurse-led research in the region. So I'd encourage people who are interested to reach out to the speakers today, and we look forward to sort of continuing this discussion and planning additional events to bring people together to discuss and support your research ideas. All right. Well, with that, we'll wrap up. And I'd just like to say a huge thanks again to ACTnet, and in particular, Nishita, who's done a huge amount of work behind the scenes organising this event. So thank you very much. And to Andrew Burke as well. Thanks to all of the speakers today and for everybody joining online. We really appreciate your interest and attendance at today's session. Also, a big thanks to the TB Nurse Consultant Group of Australian Respiratory Council, in particular Amanda, Kerrie, Jabel, also Peter Massey and Sue Devlin, who unfortunately weren't able to join us today. So thank you, everybody, and look forward to our next session. Thank you.
Thanks, Chris. Thank you, everyone.